Introduce me.
Hi. So I'm happy to introduce Dr. Caitlin Dunne today. Dr. Dunne is one of the co-directors of PCRM and my partner. She's also a clinical assistant professor at UBC. She went to University of Western Ontario for medical school, then came out to BC and completed residency and fellowship at UBC with fellowship in reproductive endocrinology and infertility. Dr. Dunne's interest is in infertility, transgender care, and LGBTQ care, and egg freezing. She's on the editorial board of BCMJ, and she was named one of Canada's top 40 under 40 in 2019. I look forward to hearing Dr. Dunne speak on donor eggs.
All right. Thank you very much, Dr. Havelock. So, donor eggs. What I want to do in the next 25 minutes or so is start off by giving you some history and historical context on donor eggs, and then we'll talk about how they're used today. We're going to also talk about the indications for donor eggs and then how we use them in the fertility clinic for treatment of infertility. And then we'll talk about how you as care providers in the community should care for women after treatment with donor eggs, specifically maternal risks, neonatal risks, and the prenatal screening options. So egg donation involves using an egg from a fertile woman to create a pregnancy in an infertile woman by means of in vitro fertilization. And that means that the woman receiving the egg will not be genetically related to the offspring, but she would be considered the birth mother. So important timeline of donor egg history. Now, the world's first IVF baby was born in the UK in 1978. That was Louise Brown. And so IVF in general is a relatively new technology. Throughout the 1980s, laparoscopy was used to retrieve eggs for in vitro fertilization. And even as that technology was evolving, it was actually 1984 when the first birth from a donor egg occurred. Now, interestingly, that birth was actually from in vivo fertilization, where the anonymous egg donor was inseminated, and then uterine lavage was performed at precisely the right time to recover the resulting embryo, and then that embryo was transferred into the uterus of the birth mother. Since that time, egg donation has come a long way, and the next major breakthrough in egg donation was in 2012 when the American Society for Reproductive Medicine removed the experimental label from egg freezing. And that meant that egg freezing went mainstream. So women were freezing their eggs for social reasons, but also a whole slew of egg freezing clinics popped up in the United States to form egg banks. And now it's no longer considered experimental, and the majority of the eggs we get are from those banks in the United States. So here we are in Canada. The latest data from the Canadian Fertility Society is 2018 data. And in 2018, donor eggs were 10% of all fertility treatment cycles. And that was double in about 5 years. So in 2018, 3,055 cycles compared to 1,587 in 2013. So I think it's fair to say that egg donation is really ramping up in use and in popularity. So the main indications for donor egg are advanced reproductive age, diminished ovarian reserve, poor oocyte or embryo quality in prior attempts at IVF, hypothalamic hypogonadism, or women who choose donor eggs because they don't want to pass on a significant genetic defect. Now, by far, in practice, what we see is the most common reason for donor eggs is advancing maternal reproductive age. And these are 2015 statistics from BC, the latest that are available on their website. And you can see there that the large majority of births in our province, at 58%, are occurring to women between the ages of 30 and 39. And if you look at this graph, you'll see I put a big green line on the screen there, and that's 30 years old. The green line, the lighter green here at the top is the first baby. The pink is the second baby. The brown is the third, and the gray is the fourth. And what you'll see there is, especially for the second, third, and fourth children, the large majority of births are happening to women over 30. So that's a pretty dramatic shift when you think about evolution. In hundreds of years, women were having babies predominantly in their 20s. And now in the last generation, we're seeing a shift where the majority of our patients are having babies in their 30s. And that has implications for their fertility. Now, the main reason is because older eggs just don't work as well. They're more prone to aneuploidy, and it's probably because of dysfunction at the level of the meiotic spindle, as well as mitochondrial deficits, which are sort of broadly considered the energy cell of the egg. And those mitochondria have presumably been with those eggs, at least some of them, since the eggs were created at 20 weeks gestation in the mother's uterus. So just a quick refresher on meiosis. When eggs are arrested in the ovary, they are sitting in prophase of meiosis 1. And the stimulus to resume meiosis happens at the LH surge mid-cycle. So what we can see here, if you can see my cursor on the screen, is the oocyte going from meiosis 1 through the reduction division to metaphase of meiosis 2. And that means that half of the chromosomes should go into the first polar body. And then fertilization is the final key to complete meiosis, where the second set of chromosomes goes into the second polar body. So non-disjunction is one of the things that can go wrong in older eggs. And this is just one example of how that can happen. What you can see here in this example on the right side is that the initial division happened correctly, but in the second division, there was one polar body that ended up with 2 chromosomes and maybe nothing left in the egg, or vice versa. And so that would result in either, when the sperm enters, if there is nothing left in the egg, a monosomy, or it could result in a trisomy if both chromosomes from both sister chromatids from the mother are left in the egg. And so for the most part, those are not compatible with a viable pregnancy, with rare exception, for example, Turner syndrome, where there's monosomy X, or trisomy 21, which is Down syndrome. Now, when I talk to patients, I reassure them that Mother Nature is never perfect. So it's really important to keep in mind that even women in their 20s have miscarriages about 15 to 20% of the time. And I try to reassure patients that this is normal. However, as we get older, a 40-year-old woman, when conception happens, it would go wrong about 50% of the time. And by the time you're 45, it's 80 to 90%. So in many cases, donor eggs offer a chance at pregnancy when there would be no other way. In the fertility clinic, how do we use donor eggs? So a lot of my patients tell me that looking for donor eggs is kind of like online shopping, and they're not wrong. What they would have to do is create a profile with one of the donor egg banks in the United States. And when they do that, this is an example of what they would see. So generally, the people that are looking for donor eggs could be infertile couples. They could be LGBTQ couples, such as gay men who are going to use a donor egg and a gestational carrier, or trans couples who choose not to use their own eggs. Or it could be women of advancing reproductive age when they've surpassed the 45-year-old age limit that we have for IVF with their own eggs. And when they go online, they can search for the donor eggs by race, hair color, eye color, etc. And you will see pictures of the donors. There's all kinds of information there, sometimes childhood pictures, adult pictures, a personal statement, whether the donor has any children of her own, all kinds of medical screening. Now, I caution patients that we can only report what we can test for, and there's not a test for anything. So not a test for everything. So one of the common questions I would get asked is like, well, what about things like mental illness, or what about things like autism? And I tell patients, well, if you don't tell me that you have depression, then I don't know. So donor screening is as robust as it can be. The long list of recessive genetic conditions that they screen donors for is getting longer every day. But of course, it's only as good as the donors report at the bank. Now, this is big business, and these donor banks really want to provide good quality eggs and a good product to their customers. So generally, it's quite robust, and I can't think of an example where it's been problematic, but it is something to keep in mind. So the donor banks are located in the US because these donors can be compensated financially. In Canada, according to federal law under the Assisted Human Reproduction Act, it's a crime to pay anybody for their gametes. That can be sperm, eggs, or surrogacy services. And so you can use donor eggs from a known donor in Canada if they're given altruistically. But paying for eggs in Canada is punishable by 10 years in prison and a $500,000 fine. So there is really no frozen donor egg bank market here in Canada, and most of the eggs are coming from the US now. In the US, donors are compensated financially. Generally, it's in the range of $5,000 to $10,000 US, although it's not something that the banks readily disclose per donor on their website. There is an American Society for Reproductive Medicine statement on donor compensation, and it is deemed to be ethical. They do say, however, that compensation should be a reflection of the donor's time, discomfort, and inconvenience, and not proportionate to the number of eggs obtained. On average, they're probably getting about 10 eggs per donation, but obviously that would vary tremendously with that particular donor's ovarian reserve. And generally, you'll find that these women are in their 20s or early 30s. Many of them have proven fertility. Interestingly, it has been examined whether these donors would suffer from premature diminished ovarian reserve as a result of egg donation, and it appears that they do not. A study that looked at anti-Mullerian hormone, which we know is a validated marker of ovarian reserve, did not seem to deplete even after 5 egg donation cycles. And that makes sense because when we do IVF, what we're doing is stimulating the cohort or batch, as I say to patients, of eggs that are available that month. All of those eggs would generally die that month if they're not used, and the next month a new batch would be available. So it makes sense that when these eggs are removed, the donors are not suffering from premature depletion. So usually the egg banks sell frozen eggs in lots of 6. Sometimes they get a few more if there's an odd egg remaining from a certain donor. Generally, Canadians will pay between $20,000 and $24,000 for a single cycle of donor eggs. However, donor egg banks do offer different plans, such as assured pregnancy, where they'll replace the eggs if the patient qualifies for the program and keep giving them eggs until they're pregnant, and those can cost a lot more. But all in, including the fertilization, transfer, etc., a good ballpark range is $20,000 to $24,000. So these eggs are vitrified, and I've shown you an example of what they look like here on the screen. You can see the shell or the zona pellucida of the egg here. And then the ooplasm inside is exposed to high levels of cryoprotectant and dehydrated. So my lab took these pictures for us. Now, vitrification is otherwise known as flash freezing, and the eggs are stored at -196 Celsius in liquid nitrogen. And that's because hopefully they don't undergo any damage or freezer burn during that process, which is much more effective than things used to be when we used slow freezing. So after the eggs arrive in our lab, it's important to treat them with extreme care because they are at metaphase of meiosis 2. And that means that the meiotic spindle and all of the genetic delicate material is splayed out. So any type of ice crystal formation or mishandling of the eggs, it's only one cell. There's zero room for error there. So that could result in killing the egg. And then after the eggs are warmed, as we say, then they look like this. And you can see here that the ooplasm is light and the egg looks healthy. The ooplasm membrane here is intact. So this is a nice set of donor eggs, pictures taken just last week by our lab here. The setup for warming donor eggs looks like this. So all of these all of the manipulation has to be done under a microscope. Now, as you well know, the ovum is the largest egg in the largest cell in the human body. So it is visible with the naked eye, but not very well. So the manipulation is done under a microscope. The warming procedure is carefully timed. So you can see that my embryologist has a timer set up here for the different solutions. This is the eggs still submerged in liquid nitrogen, and they're stored 2 per device on these little tiny devices. And when they warm the eggs, they put them into a solution, and I'm just going to show you a video of one of our embryologists doing that here. So she's freeing up the egg from the device, and then she's searching for the egg with her pipette. And then the egg would go through a series of warming solutions to rehydrate it. And all of the eggs that are previously frozen need to be fertilized by ICSI, and that's because of changes to the zona pellucida that make it less competent for regular fertilization by in vitro fertilization, meaning that we have to actually inject the sperm into the egg. So I'm going to show you a video of us doing that here. You can see the little sperm is here in the needle, and the embryologist is just going to gently bring the sperm to the tip of the needle and then puncture the zona pellucida and the ooplasm. And then they suck up some of the ooplasm and then see if you can see the sperm race by as they inject it. There it goes, and gently withdraw the needle. So that's how we would fertilize previously frozen eggs. And I have to give a shout out because exactly tonight at the American Society for Reproductive Medicine Awards, one of our embryologists, Jason, is getting an award for the highest donor egg pregnancy rate in Canada from Donor Egg Bank USA. So how well do these eggs work? The answer is there's very good data that they work as well as fresh eggs, particularly in the donor egg population, which is younger women. I'm going to summarize for you some of the data from the American Society for Reproductive Medicine guideline on the topic. They looked at 4 randomized control trials. 2 of those trials were in women using frozen donor eggs, and 2 were in women using autologous oocytes. Overall, they found that the egg survival rates were 90 to 97%. Fertilization rates were 70 to 80%, which is normal. And the clinical pregnancy rates ranged from 36 to 61%, which was no different than for fresh eggs. And then in another very large trial comparing over 100,000 fresh autologous cycles with 2,223 frozen donor egg cycles, confirmed that frozen donor egg success rates are equivalent to those of fresh eggs. There's also data looking at the offspring of frozen donor egg cycles, and the American Society for Reproductive Medicine concluded that there's no increase in chromosomal abnormalities, birth defects, and developmental deficits in offspring born from cryopreserved oocytes when compared to conventional IVF and ICSI. So this is Canadian data, the most recent that we have available, which is 2018. And what you're seeing here is the age of the recipient. And what you'll see is no matter the age of the uterus that the egg goes into, donor egg pregnancy rates are consistent across the lifespan. So that just shows us, again, that the egg and aging of the egg is the main driver for infertility, and we generally say that the uterus doesn't age. So when we actually do a treatment on your patients with frozen donor eggs, it's very similar to that of a frozen embryo transfer, which means that they would take estrogen tablets. The tablets are 17 beta estradiol, and they would take those for, on average, about 14 days. And that just serves to get the endometrium to grow. And then it also suppresses their folliculogenesis and ovulation. Having a normal menstrual cycle is not a prerequisite. So even women in menopause can respond to estrogen. So that means that women who've gone into menopause or those with premature ovarian failure or irregular menstrual cycles can undergo frozen donor egg treatment. Now, we always tell our patients, of course, that the future genetic test would show that the child is biologically related to the father and not to the birth mother. And because this woman who's carrying the pregnancy does not have any endogenous progesterone production, because she did not make a corpus luteum, it's absolutely essential that she remain on progesterone until at least 7 weeks, generally because we're superstitious and we like to be careful. We generally keep them on progesterone until 10 weeks. And then at that point, usually around the 7-week mark, the placenta will start to make its own progesterone. So this is just a diagram of one of the ways that donor eggs are used, but of course that doesn't take into account the many other ways donor eggs can be used, such as for single women, if they want to use it with donor sperm, for trans and LGBTQ couples and gay couples as well. Okay, so with donor egg pregnancy rates being as high as they are, us in the fertility clinic have the easy job of getting them pregnant, and then we send these patients to you in the community. And what do you need to consider when caring for these women? So, of course, the number one consideration here is maternal age. In Canadian clinics, the upper age limit for treatment with donor eggs is 50 years old, and in the US, the guideline is 55. So we do have some women in their late 40s who are conceiving with donor eggs. Generally, we would advocate for a multidisciplinary approach. Our approach is that anybody over 45, we would usually send a referral to maternal fetal medicine or involve their OBGYN ahead of time to see if there's any pre-screening or specific counseling that needs to be done. But of course, every patient would have the team of doctors that would be appropriate for them, including the family physician, OB internist, OBGYN, or maternal fetal medicine specialist. Depending on the health and the age of the patient, you might consider additional screening for cardiovascular disease, whether that's looking at things like their lipids ahead of time and optimizing their health, screening for diabetes as well. Generally, I do ask the family doctor to consider mammography only because if the patient does conceive and then there's a period of lactation after that, if they were due to have a mammogram starting at 50, then that could be delayed by a couple of years. And everyone undergoing treatment with donor gametes would be asked to have an assessment by a psychologist experienced in third-party reproduction. The second concern is with gestational hypertension and preeclampsia. There's quite a bit of retrospective data that suggests that hypertension and perhaps preeclampsia is more likely in patients who get pregnant from donor eggs. For example, one study looked at 217 egg donation pregnancies compared with 363 autologous egg pregnancies. And they found that the pregnancy-induced hypertension was 17.8% in the egg donor group compared with 5.3% in the autologous group. And preeclampsia was also more common, 11% in the egg donor group versus 2.8% in the autologous group. And actually, eclampsia didn't occur at all in the autologous group, and there were some cases of eclampsia in the egg donor group. So it's certainly something to keep in mind. The proposed pathophysiology is that there could be an immunologic intolerance between the mother and the fetus, leading to placental maladaptation. So of course, every pregnancy is, a foreign thing that's growing. So it does require some immune downregulation, but perhaps egg donor pregnancies require a higher degree of downregulation from the maternal immune response to allow for more mismatches in the HLA system. The converse argument to this is that there is some data that the increase in gestational hypertension might just be due to confounding patient risk factors, such as age, which even in studies are controlled for as covariates, but not, perhaps there are inherent patient characteristics with these that we can't completely tease out. And now, so finally moving on to prenatal screening. So for you in the community, the bottom line is most types of prenatal screening are valid in this setting. So that would include integrated prenatal screening, serum integrated prenatal screening, first trimester screening, quadruple marker screen. Now, the requisition will often request the birth date of the egg donor because a test's positive predictive value varies with the prevalence of a given disorder. And you can also use NIPT in egg donor pregnancies. So that is a test that the mom gives a blood sample and it sequences fragments of placental DNA that are circulating in the woman's blood. Now, the only caveat there would be twin donor egg pregnancies. They could possibly contain too many DNA profiles for some single nucleotide polymorphism microarray platforms. Not all of them. And twin donor egg pregnancies are very, very rare because we almost always, not always, but almost always transfer one donor egg embryo at a time because they are such high success rate. Okay, so that is the end of my talk. I will open it up now to conclusions. So donor egg pregnancies are common and rising in popularity. Most commonly, they're used for premature menopause, advanced reproductive age, or prior unsuccessful attempts at IVF. In general, you get 6 eggs. They're shipped from the US, and the cost to the patient can be $20,000 to $24,000 Canadian. Care providers should consider increase in antepartum risks, such as maternal age and gestational hypertension related risks. And almost all prenatal screening options are still valid. All right, thank you so much.